Hello, my name is Dr. Padraig Suluwa, and I'm a neurologist at UT Southwestern. I'd like to talk to you about the outpatient testing for normal pressure hydrocephalus, or NPH. If we ask you to watch this video, it usually means that we have seen you in NPH clinic and have thought, based on your history and exam, that there is a reasonably good possibility that you have normal pressure hydrocephalus. And we are recommending, in your case, the outpatient testing pathway. I'd like to share some images with you to discuss this. So the outpatient testing is for diagnostic/prognostic purposes. Diagnosis is to try to ascertain if NPH is likely what's going on, and prognostic testing means to help us determine if treatment is likely to help you. They're two different, slightly different questions, certainly are related, but the testing we're doing is for both purposes. There's not an absolutely great test for normal pressure hydrocephalus. Instead, there are pieces of information that are more or less supportive of NPH being the problem and a shunt being a good solution. So we collect up all the bits and pieces of evidence based on your history, your exam, and these tests that I'm going to talk about here. And based on the accumulation of all that information, make a decision. You're more likely to be helped rather than hurt with a shunt. The nature of the testing that we're planning for you in the weeks ahead is as follows. First, well, one test is a brain MRI done with an NPH protocol. Now, many of you will already have had a brain MRI done, and sometimes the quality of that brain MRI is good enough, and we don't need to do any more MRI. Sometimes the brain MRI quality that you have or the nature of the sequences done in the scan are not informative enough. We recommend you do an additional brain MRI with NPH protocol. So that's not for everybody, but if we order it, that's for you. And next test is a baseline gait and balance assessment, followed by a large volume lumbar puncture. And I'll get into more details about each of these in the next few minutes. 2 days after that lumbar puncture, you'll come back to us again and we'll do follow-up gait and balance assessment. And we'll do follow-up cognitive and memory testing. As you may remember, you had cognitive and memory testing as part of your outpatient NPH clinic evaluation. And we like to recheck that 2 days after you've had the lumbar puncture to see if we see any changes in that. And then 1 to 4 weeks after these tests, we'd like to see you back in clinic. We'll review with you how things are doing and discuss that decision, whether to do a shunt or not do a shunt. So a bit more detail about each of these steps. First, the brain MRI with NPH protocol. If the scan is necessary in your case, it does need to be done at UT Southwestern. Patients sometimes ask, can I do this at my local center for various reasons, convenience or even coverage? But I'm afraid there's no other center that does the NPH protocol that we're talking about. If you do the scan, it'll be usually done at the Rogers MRI Center, which is at the Bill and Rita Clemens Imaging Center. Let me show you where that is on this map. Here is Harry Hines, Inwood, Forest Park, and here's the Bill and Rita Clemens Advanced Imaging, and within that, there's the Rogers MRI Center. And that's often where we send you. Certainly there's parking, including valet parking or self-parking in that region of the campus. We may send you to another MRI scanner, in which case we'll tell you, but if it's the Rogers, which it usually is, then that's where it'll be, at the Bill and Rita Clemens Advanced Imaging Center, the Rogers MRI within that. The scan itself will take less than 30 minutes. It needs to be completed before the LP is done. The LP changes your brain scan appearance on this protocol. So we need to have the MRI done before you have the lumbar puncture. Could be done an hour before, it could be done a week or a month before. Doesn't matter too much. We have set aside some slots at 8 a.m. and 8:30 a.m. every Tuesday morning for people who want the brain MRI NPH. So if we ordered that, you can have it done in those times. We did that because the other tests we're going to talk about next are going to happen later on Tuesday mornings. And for people who are coming from a distance and want to do it all in one trip, then it's convenient. You do the MRI first, and then you scoot across campus to the subsequent tests later on the Tuesday morning. If you're coming from close by region, you want to spread out your testing and not be hustled and spread them across different days or weeks, you could do this one Tuesday and then come back a week or two later and do the lumbar puncture and baseline gait and balance assessments. The baseline gait and balance assessments and the large volume lumbar puncture are done on Tuesday mornings, late Tuesday mornings, 11 a.m., noon, 1, something like that. And these are usually done at the UT Southwestern Cancer Center outpatient building. Let me show you where that is on campus. So here's Harry Hines again. Here's Inwood. Here's that Forest Park you saw, and the cancer center, the imaging center was here. The cancer center is it's a fairly short walk, but almost everybody is going to drive to it. You can either drive around this way and park here, the south parking or valley parking, or you could drive from the cancer center around here, south parking here. Again, it is not difficult, I think, to walk through the building. It's not difficult for us, but it is a few buildings you have to navigate through, and the skyway and passage and so on. And it may or may not work out. And for most people, I suspect it's better off to get back in their car and drive around to the cancer center. We do in the cancer center because we could arrange for outpatient lumbar puncture at that location and the baseline physical therapy and gait and balance assessment. And we wanted them done in the same place or same region, as close as possible on campus. That's why it's not because of cancer. This condition has nothing to do with cancer. So on the Tuesday mornings, the baseline gait and balance must be done before the lumbar puncture. We have you walk 10 minutes, usually do that twice. We do some balance testing, standing on one foot, standing on 2 feet, walking tandem, things of that nature. We have you turn 360 degrees in each direction. We count how many steps it takes, how long, things of that nature. Then the lumbar puncture. This is you lying in on your side, and we insert a needle here, initially with lidocaine to numb up the skin, and then a few minutes later, follow up with another needle to pass between these bones and the vertebrae to get into the spinal fluid, which is just below the bones. This is below the end of the spinal cord, but there are some nerves still passing through here, going down to your legs. So there's some local anesthetic injected in the low back region, but we don't give sedating medications or oral medications. It's not general anesthetic. It's just local anesthetic to numb up the skin a bit. You're still going to feel the needle inserted in the lumbar space. Sometimes it's painful, like any needles for drawing blood or things of that nature. Sometimes the pain can radiate down to your leg, indicating we're tweaking a nerve there. We'd like to know about that and relocate the needle. And then once we have the needle in the space, we'll drain off 30 or 40 mils of CSF. And that's, I guess, 3 or 4 teaspoons or tablespoons, I think, if we got the measures right, tablespoons. And then we send that for protein analysis. But the main purpose is to reduce the volume of CSF, cerebrospinal fluid. So that's the purpose for the testing. The procedure itself can take roughly 20 minutes. We'll put a Band-Aid on, and sometimes we'll have you rest laying down for a while, or sometimes we'll have you getting up and getting on with your day. At that stage, you can go back home and you're on your own for a few days. Possible side effects include headache. It can come on the day or two later. Hopefully as a temporary thing or minor if it happens. Most people doesn't happen at all. Some people get back pain. Usually it's temporary. Sometimes it goes on for days or could be even longer. There's a low possibility that we'd injure your nerves or blood vessels or introduce an infection in doing this test. Now, 2 days later, we'd like to bring you back and examine you again. And this is usually on the Thursday of the same week. Come back to the same location for the gait and balance testing, and the same series of tests is done by the physical therapist. And we compare essentially with the Tuesday before the tap to how you are on the Thursday after the tap. We'll also do the cognitive testing, similar to the tests that you had in the NPH clinic, memory testing and things of that nature. The location of this testing depends on the availability of rooms and psychologists. So I can't verify that now, but the scheduler hopefully will tell you. And then we schedule a clinic appointment to review the results. Usually this is done in the Aston Clinic, usually with a neurosurgeon, and fairly often in person. There are variations on that if needed for you or for us. Your case will be reviewed, including your tests and your experience of the tests. And the key question on the table at that time is whether a shunt is likely to help you or to hurt you. Certainly shunts, inserting the tube into the brain to drain off the fluid, is a significant procedure. It carries certain risks of bleed in the brain, infection, failure of the shunt, and has a certain likelihood of helping, a certain likelihood of hurting. And we tried to assess how likely you are to help you based on the tests so far that we talked about in your history and your exam and so on. And we also try and factor in how likely we are to actually make things worse. And ultimately, the surgeon will take responsibility for making a recommendation to you. I recommend we do the shunt or recommend you not do the shunt. And you'll have to decide whether or not you want to accept that recommendation. You'll have appropriate questions. If you and the surgeon decide, yes, a shunt is what's going to happen, then the surgery schedulers will get with your insurance, get with the hospital schedule, and try and figure out a time frame for the shunt procedure. It can take a couple of months to line that up. And their clinic will coordinate with you for organizing that and the post-hospital care. If a shunt is not planned, well, then your care can be returned to the referring physician. Well, I hope that helps you understand a little of what's going on with the outpatient testing pathway for NPH. Thank you.